Yeah, it's lighter, but it's still like that.
Morning.
Morning, sir.
Morning.
You didn't?
I don't have any new patients in my service. It just be with it. How's that going?
It's not.
Yeah.
I don't know if it's in the wheelhouse.
Where are you?
I think I'm on stress.
I'm expecting a minimal.
I'm wondering what
I think she's really blind.
Oh, you're we together now?
I'm on my
All right, getting a man now.
We're always together. I think that's over. Fourplex.
I saw.
Why they didn't show up?
I saw too cool.
Oh, boy. What are they all? Did you call the thing to check you see for the lecture?
Really?
Well, it's like a little on the door. There's a phone number you have to call to check.
But it's like.
Yeah, it's like then they go into the steel
And then the lady that I was with.
Steve, I don't think that's for you. Did you see this?
Yeah, we were just standing outside doing it so we wouldn't disrupt you.
Oh. I hope you and yours had a good holiday in Fort Smith.
We're gonna go back up there this afternoon. We're up there trying to get ready to have all the kids for Christmas. They don't want them in Little Rock.
Well, I don't mind.
Oh,
How about the grandkids?
there'll be 9 of them.
Boy,
You gonna have a big Christmas?
well, it'd be the usual. Everyone except Vince and his family and Hawaii. Vince is visiting me right now, and I have found one usefulness for these newfangled cell phones in that with the newfangled cell phones, as you all know, that I had kept up with, call the children over there, you know, can look at them and talk to them, and they look at you and talk to them. I finally found a use for that.
Well, we still don't I don't need it. My wife, she has a fancy phone. I got a $10 Walmart special.
Well, see, now that's all I got. See, this is all I have.
Yeah.
It serves my purpose.
And when I drop it in the Arkansas River, it doesn't make my heart. There goes
Good morning, everybody. I think that we should start now because it's raining outside, and I think the rest of us is going to come a little bit later. And this is, there's kind of a lengthy presentation, so we want to be able to finish. This morning, we're going to dedicate some time to talk about the monoclonal gammopathy of undetermined significance and the neuropathy, and trying to review the association between those two. The objectives of the talk are listed here. Is to select laboratories to detect a monoclonal gammopathy in a patient being evaluated for peripheral neuropathy, to use the electrophysiologic phenotype to determine the possible relationship between a monoclonal gammopathy of undetermined significance and a peripheral neuropathy, to be able to predict the response to treatment of a paraproteinemic demyelinating neuropathy of the GUTS IgM phenotype, either MAC positive or negative, and to consider when a nerve biopsy can be helpful or necessary in a patient with MGUS and neuropathy. In this lecture is directed to our residents, maybe, those are the people that we're trying to teach with this. So some of these things are going to be very simple for our specialists, and they're going to be very difficult for our medical students, but I think it's necessary to review these concepts for all of us, particularly for the neurologists in training. So this is a case that was referred to us from the hematology department. Dr. Mehta asked us to see a patient for neuropathy as it may relate to MGUS, including, if necessary, evaluate to see if it's necessary to have a biopsy or to provide association. She thinks that would be an indication for treatment. So this is a patient that Dr. Mawala has seen. The patient presented with a tingling and numbness in the right lower extremity, more than the left lower extremity, for a year. He's 66 years old with a history of MGUS IgM for 1 to 2 years. Is familial. Presents for evaluation of tingling and numbness. The numbness in the lower extremity is mostly in the right toe and the sole, and also in the tips of the left toes. It feels like a shooting pain with some numbness in the fingertips that has resolved in the last 6 months. He was started in back pain 3 weeks ago, and it's not getting better. His balance is off and leans to the right, and has had no falls. And the rest of the history is really non-contributory. They do say he has colon surgery, status post colectomy, and the oncologists were following him for that. He has no urinary problems. He has some erectile dysfunction. That could be important. August 2013 is when he started. Never tried medications. No problems with sweating. So the autonomic dysfunction is being reviewed in our history. Added smoking only for 3 years while in college. Drinks 1 glass of wine twice a week with dinner. And the family history has a familial history of MGUS from the father, brother, and sister. The physical examination is benign. The lungs are clear, the heart is normal, and they don't mention anything about organomegaly. Mental status is normal, cranial nerves are normal, including the pupillary reflexes. Motor strength is good and has some weakness of the right extensor hallucis longus. Normal tone, limataxia is normal, and there's no involuntary movements, which is a good notation too, because some of these patients can have tremors. Has a wide base gait, has some decreased pinprick of the toes in stocking fashion, has some decreased proprioception in the right toe. Vibration is reduced in the toes and ankles, and the reflexes are 1+, except for ankle reflexes that are absent. So let us talk a little bit about the statistics of neuropathy and monoclonal gammopathy, so we can have an understanding of the type of problems that we may be facing when we evaluate these patients. The prevalence of neuropathy rises with age. I guess we all understand that. As you're getting older, there is a likelihood that you will develop a neuropathy. It's present in 8% of the subjects of more than 60 years. Also, the monoclonal protein prevalence increases with age. Can be seen in 3% of the patients more than 70 years and 10% of the patients over 80 years. So the coexistence of neuropathy and monoclonal gammopathy represents a common but complex problem in clinical practice. Although a coincidental association cannot be excluded, in a significant proportion of cases, there are a number of entities where a direct link exists and needs to be recognized. So this is an outline of what we're going to try to cover today, this morning. We're going to try to define what is the monoclonal gammopathy, what is the monoclonal gammopathy of undetermined significance. Then we're going to talk about a specific phenotypes. We're going to talk about the DATS phenotype. We're going to talk, which is IgM, anti-MAC positive or negative neuropathy. We're going to talk about the monoclonal gammopathies resembling, with neuropathies resembling CIDP. We're going to talk about the monoclonal gammopathies with associated axonal neuropathy. And then we're going to spend a few minutes talking about some of the malignancies that could be seen in patients that have paraproteinemias. Primary amyloidosis, Waldenström macroglobulinemia, multiple myeloma, and Foyne syndrome. And I brought this because I think that some of these malignancies have things on the history and physical that we can pick up and we can use to have an idea that we have to, pursue strongly to see if there is an MGUS in this patient. So, defining what is a monoclonal gammopathy. Monoclonal gammopathies, or M proteins, are produced by a clonal population of B lymphocytes or plasma cells. The immunoglobulin molecule is composed of 4 chains, 2 identical heavy chains, and 2 identical light chains. The heavy chain is commonly IgG, IgA, or IgM, and rarely IgD or IgE. And the light chain is kappa or lambda. As you will see, it's important to know, what is your heavy chain and your light chain, because you can use tables, reference tables, to see what kind of neuropathy is associated with the particular heavy chain and light chain. So this is the immunoglobulin structure, and it's showing the heavy chain in the inner part, the light chain in the outer part. And just for you to have an idea of what we're talking about. So what laboratory evaluation should we do for a monoclonal gammopathy? And this would be like a minimal evaluation, the evaluation that we're going to do to screen to look for a monoclonal gammopathy. There is a lot more to it, and usually with these 3 studies that we're going to discuss, we can kind of detect if there is a monoclonal gammopathy, and from there on, probably is advisable to send the patient to a hematologist for them to do further workup. So the things that we want to do is a serum protein electrophoresis, and we're going to do a serum immunofixation electrophoresis, because sometimes the serum protein electrophoresis can be normal, and you can still have a small amount of an M protein that is not detected by the serum protein electrophoresis. You also need to do a serum free light chain, because sometimes some of these disorders produce an increased amount of the free light chain, and the rest can be normal. So if we do at least these 3, then we will be picking up most of these disorders. There's other evaluations that are done if one of these 3 is abnormal. We would try to quantify the M protein by doing additional testing. And that's as much as I'm going to discuss about this at this moment. So far, if we do these 3, I think we're going to be picking up most of these disorders. The monoclonal gammopathies, as I said, are produced by a clone of plasma cells in the bone marrow. The proliferative process can be low-grade, as in monoclonal gammopathy of undetermined significance, or it could be a malignant process, as in multiple myeloma or Waldenström macroglobulinemia. The associated neuropathies with the monoclonal gammopathy can occur in various clinical, electrophysiological, and pathological forms. The presence of a paraprotein itself raises a number of possible hematological diagnoses. Consideration to a hematological consultation should be given at this point when we identify the monoclonal protein to identify and monitor a malignant process. A bone marrow examination is usually performed in patients with an M protein level of more than 15 grams per liter, although some hematologists perform it in all patients with monoclonal gammopathies. The most common hematological diagnosis that the patient is going to receive after they visit the hematologist is that they just have a monoclonal gammopathy of undetermined significance. And this is diagnosed in the absence of malignancy. MGUS accounts for 2/3 of the paraproteins. It's characterized by a level of monoclonal protein less than 30 grams per liter, less than 10% of plasma cells in the bone marrow, no or only low-level monoclonal protein in the urine, absence of anemia, hypercalcemia, bone lesions, renal failure, and stability of the monoclonal protein. So it's quite a bit of evaluation that our hematologist is going to be doing. MGUS may transform into a malignant process, and the annual risk of transformation is about 1% per year. So patients that have a monoclonal gammopathy of undetermined significance need indefinite follow-up with annual SPECT and levels of the monoclonal protein. Monoclonal proteins commonly co-occur in peripheral neuropathy. One study reports an incidence of up to 10% in a tertiary center. The presence of a monoclonal protein does not automatically imply causality of the neuropathy. So the fact that you found a monoclonal protein does not mean that that's causing the problem. It is important to determine whether the neuropathy is due to another cause and the association with the paraprotein is simply a chance association, or whether the neuropathy is secondary to the process causing the paraprotein. Malignant hematological disease with monoclonal protein may also be accompanied by a neuropathy. So now we're going to be talking about demyelinating neuropathy. So at this point, we already saw the patient and ordered some testing. We feel the patient has a monoclonal gammopathy, went to the hematologist, came back with the diagnosis of MGUS, and we're doing a nerve conduction study. We do a nerve conduction study and try to classify if the patient has a demyelinating neuropathy, an axonal neuropathy, or if he has a normal nerve conduction study. So this IgM MGUS anti-MAC antibody neuropathy has a phenotypically characteristic neuropathy described as distal acquired demyelinating symmetric sensory and motor neuropathy. We're going to call this that. And this particular phenotype is the one that is more clearly associated with the IgM MGUS. This is the one that is hard to treat, that doesn't respond to the things that you would treat CIDP with. This is the one that we probably don't know how to treat yet, and some people try to treat with rituximab and other things. So this one is a predominantly distal, usually very slowly progressive, with a prominent sensory involvement, sensory ataxia, little or no weakness, and frequent tremor. This neuropathy is associated with autoantibodies to myelin-associated glycoprotein, MAG, which is a constituent of normal peripheral nerve myelin. The IgM monoclonal protein binds to MAG in 50% of the patients with IgM MGUS. So MAG positive or MAG negative is still hard to treat. This results in characteristic changes in peripheral nerve myelin lamella. And this is a figure showing a pseudo nerve specimen where there is widely spaced myelin involved in the central lamella. You can see compacted lamella in the inner part and in the outer part, and you can see the widely spaced lamella in the center. And this is what they will see in electron microscopy. The anti-MAG neuropathy can also occur with concurrent Waldenström macroglobulinemia and B-cell lymphoma. The diagnosis of anti-MAG neuropathy relies on the identification of an IgM paraprotein on SPECT immunofixation, as well as the presence of high levels or titers against the peripheral MAG. Electrophysiologically, anti-MAC neuropathies demonstrate generally diffuse, absent, markedly reduced sensory action potentials. The motor nerve conduction velocities are significantly slow, but the degree of distal slowing and the prolongation of the distal motor latency is much greater. So looking at distal motor latencies is very important on trying to distinguish your common CIDP patient from the DAX phenotype patient. This causes a reduced terminal latency index, and there is an equation to determine that index. So on patients that have DAX phenotype, it's going to be less than 0.26, and patients that have CIDP is going to be more than that. So conduction block, abnormal temporal dispersion, and abnormal median and normal pseudosensory nerve action potentials, which are features of CIDP, are not present in patients with anti-MAC neuropathy, presumably because the pathophysiology is length-dependent with uniform demyelination. So conduction block, and you know when you do your CIDP evaluation, sometimes the pseudo nerve can be spared. So this is not what you're going to see on this DAX phenotype. Nerve biopsies demonstrate loss of myelinated fibers and axonal degeneration with deposits of IgM paraprotein and complement on nerve myelin. The electron microscopy usually shows widening of the myelin lamella that we saw. The characteristic clinical, electrodiagnostic, and nerve biopsy findings point toward a direct pathogenic role of the anti-MAC antibody. Response to immunotherapy generally is poor in patients with IgM MGUS of the DAX-M phenotype. This is in contrast to those with idiopathic CIDP and those who have DAX without IgM paraprotein, both of whom generally respond well to immunotherapy. Rituximab has been considered as treatment for IgM MGUS DAX-M phenotype. Rituximab has been shown to be beneficial for patients with IgM anti-MAC neuropathy in several case reports, small series, and open studies. A 2012 Cochrane review did not find strong evidence to support the use of any particular immunotherapy, although weak evidence in support of rituximab was noted. A typical clinical and electrophysiological presentation of a CIDP may accompany the presence of a monoclonal gammopathy. So now we're talking about your normal-looking CIDP. Symmetrical proximal and distal weakness of the forelimbs, sensory involvement, and areflexia. Demyelination affects the intermediate as opposed to the distal segments, which are more involved in the anti-MAC neuropathy, and conduction blocks are frequent. And then here, they're showing a left median nerve electrophysiological recordings at the wrist, elbow, and axilla, and Erb's point in 2 patients. The first one on the left is the anti-MAC neuropathy, and you can see the distal latency, how prolonged this is, and this is your CIDP, and the distal latency is not really very prolonged. Takeoff is not right here. That's what they're trying to demonstrate. And then the conduction block is more evident on the CIDP. You see how they lost the amplitude. And here, you have some temporal dispersion, but the amplitude doesn't drop as much. And then here they put the terminal latency index of the anti-MAC, the terminal latency index of another one, the CIDP looking. So on that looks like CIDP. Raised TSF protein is found in about 70%. The nerve histology may show features of macrophage-mediated demyelination. The treatment of CIDP-like neuropathy associated with MGUS is that of idiopathic CIDP with steroids, IVIG, and plasma exchanges. 80% of the patients respond to one of these treatments. The treatment is not always essential as a proportion of patients stabilize without continuing the therapy. The association is at times coincidental, and some consider that the IgM MGUS is most likely to be causative of the neuropathy than the IgG or the IgA MGUS. MGUS can also be associated with a sensory or sensory motor axonal neuropathy involving distal extremities in a length-dependent fashion. But the link between the two is in that case more elusive or difficult to prove. Clinically, the usual initial presentation is one of distal lower limb sensory symptoms and signs with motor weakness at a later stage. Electrophysiologically, axonal degeneration is observed. CSF is normal, and nerve histology shows non-inflammatory axonal loss. Progression is slow and often does not require any treatment. So knowing that it's a axonal neuropathy can make us feel at ease, knowing that it's not going to be like CIDP or that's phenotype. Some patients may benefit from anti-neuropathic pain agents. Now, the problem with the axonal neuropathy and the MGUS is that some of them can actually have amyloidosis. The chronic axonal peripheral neuropathy with IgG MGUS without signs or symptoms of amyloidosis is usually indistinguishable from the chronic idiopathic axonal peripheral neuropathy. And, you know, most of our patients that we see have chronic axonal idiopathic neuropathy. The coexistence of an MGUS with an axonal neuropathy should raise the possibility of amyloidosis. 20% of patients with systemic light chain amyloidosis or primary amyloidosis present with a neuropathy. 80% demonstrate a monoclonal protein. This is most frequent IgG and lambda. The neuropathy itself is mostly symptomatic in the distal lower limbs, predominantly sensory of the small fiber and painful type, and autonomic dysfunction is frequent. So I guess that's translate on that patient that presents with a painful small fiber neuropathy, and you do a nerve conduction study, and it could be either an axonal neuropathy or a normal nerve conduction study. The patient still has the sensory neuropathy, and you have to look for your either the light chain or the monoclonal gammopathy and try to see if there is a reason, if there is an association between those two. The diagnosis rests on the demonstration of amyloid in tissue using Congo red stain producing apple green birefringence with polarizing light. And these are figures too that I obtained from, this one came from Continuum this year, a review on paraproteins by Michelle, I think, Marman. And this one is amyloidosis in a nerve. Here is the hematocylin and eosin pink staining around endoneurial blood vessels. It's pink material. Metachromatic staining with methyl violet. It's this blue material. And C is the reactivity with Congo red staining. And then when you put the specimen under polarized light, it turns like that. So this is diagnostic of amyloidosis. And this is showing the same. Here, the amorphous material of amyloid and a vessel. And here. The liver may be the most sensitive tissue to biopsy, followed by peripheral nerve or abdominal fat or the rectum. Nerve biopsy is positive in most cases with a clinically symptomatic sensory neuropathy. And the neuroamyloid deposits are identified in the majority of the cases on routine paraffin-embedded fragments, but are sometimes only visible at ultrastructural examination. The presence of an MGUS does not necessarily imply a definite diagnosis of primary amyloidosis rather than genetic amyloidosis, and low-grade MGUS being detected in about 25% of genetic cases. The prognosis of primary amyloidosis is poor with a median of less than 18 months from onset. Treatment with melphalan and prednisolone may prolong survival. Autologous peripheral stem cell transplants may be also effective in combination with melphalan, and patients are referred to specialists in tertiary centers for adequate management. And this is a very neat table that was in the same review from Continuum this year. At this point, we have talked about the immunoglobulin M monoclonal gammopathy of undetermined significance, IgM MGUS. Most commonly is an IgM kappa. We talk about the distal large fiber sensory predominant neuropathy with sensory ataxia, and it's demyelinating with prolonged distal latencies. And we have talked some about the immunoglobulin light chain amyloidosis. It's usually a lambda fragment. is axonal and causes sensorimotor peripheral neuropathy with prominent autonomic involvement. Again, this is the most common phenotype. The problem with these things is that it can cause several phenotypes. But we should remember the autonomic involvement. So the rest of the topic I'm going to spend talking about Waldenström macroglobulinemia, which is malignancy at this point, multiple myeloma, and Poem syndrome. Waldenström macroglobulinemia is an AGM-associated lymphoplasmacytic lymphoma. It presents in the 7th decade with a male predominance, annual incidence of 3.8 per million persons per year. The clinical manifestations are hepatomegaly, splenomegaly, lymphadenopathy, and hyperviscosity. The most common presenting symptom is fatigue related to anemia. The median survival is greater than 5 years, with a poor prognosis associated with age greater than 65, anemia, thrombocytopenia, elevated beta-2 microglobulin, and elevated IgM level. Neuropathy, clinically, the neuropathy is clinically indistinguishable from the IgM MGUS neuropathy. So the description, the phenotype, is about the same. The problem is that when you do the electrodiagnosis, one is demyelinating and the other one is axonal. But both have the same monoclonal protein. The most common symptoms are numbness of the feet and gait ataxia, followed by tremor, which is much less common. Autonomic involvement is limited to mild pseudomotor abnormalities. Despite a similar clinical phenotype to IgM MGUS, the electrophysiologic findings in patients with neuropathy related to Waldenström macroglobulinemia are more often axonal than demyelinating. The laboratory findings in Waldenström macroglobulinemia show much higher IgM levels and a much greater presence of anemia, which are helpful clues to the diagnosis and should prompt further evaluation and consultation with the hematologist. The patient's IgM levels greater than 4,000 are at risk. Patients that have IgM levels greater than 4,000 are at risk for hyperviscosity syndrome. Bone marrow biopsy demonstrates a lymphoplasmacytic infiltrate, and CT of the chest, abdomen, and pelvis can detect organomegaly and lymphadenopathy. The treatment is directed at patients with advanced symptomatic disease, including bulky disease, profound cytopenias, constitutional symptoms, or hyperviscosity. It consists of an alkylating agent, possibly in combination with rituximab. Patients with early disease, which includes anemia, thrombocytopenia, Waldenström macroglobulinemia, associated hemolytic anemia, or glomerulonephritis, and peripheral neuropathy may be offered rituximab. It's a plasma, talking about multiple myeloma now. It's a plasma cell neoplasm of the bone marrow that secretes a monoclonal protein in the majority of the patients. The average age of onset is 66 years. The annual incidence 4.3 cases per 100,000 people, and the cardinal clinical features of multiple myeloma are hypercalcemia, renal insufficiency, anemia, and bone disease. The diagnosis requires 10 or more plasma cells on bone marrow examination or biopsy-proven plasmacytoma, an M protein in the serum or urine, and evidence of end organ damage, including hypercalcemia, renal insufficiency, anemia, or bone lesions, believed to be secondary to the underlying plasma cell disorder. So this is a MRI, sagittal MRI, showing compression fractures here and an infiltration compressing the cord itself. And this one is a CT that shows diffuse osteopenia and lytic lesions in a patient with multiple myeloma. The most common presenting features in multiple myeloma are fatigue, bone pain, and recurrent infections. With current treatment options, the median survival is greater than 8 years. Now, the peripheral neuropathy that we're going to see on patients that have multiple myeloma not diagnosed, or patients that have multiple myeloma diagnosed, one is associated with the multiple myeloma itself, and the other one can be associated to the treatment that they receive for the multiple myeloma. So, talking about the one due to the multiple myeloma and not the treatment. Clinically, the peripheral neuropathy can be found approximately 5 to 20% of patients with untreated myeloma. The mechanism of peripheral neuropathy in patients with untreated multiple myeloma is poorly elucidated. The peripheral neuropathy can be sensory motor or sensory motor. Gradually progressive line-dependent sensory motor is a gradually progressive line-dependent sensory motor peripheral neuropathy. All sensory modalities are typically involved, and ankle reflexes may be reduced or absent. Neither pain nor autonomic involvement is prominent. The nerve conduction studies show mild slowing of motor conduction velocities and low to absent compound muscle action potentials. The sensory nerve action potentials are usually low to absent. Rare cases present as a sensory ganglionopathy, presenting with a sensory ataxia or a motor polyradicular neuropathy with facial, bulbar, and respiratory weakness. So there's a variety of presentations for these things. Treatment emergent peripheral neuropathy is the most frequent neurologic complication in patients with multiple myeloma. It can affect up to 65% of patients receiving chemotherapy. The type of neuropathy and the extent of its reversibility depends on the agent used. These agents listed here have been reported to have a lower list of peripheral neuropathy: lenalidomide, carfilzomib, and pomalidomide. This table from the same review shows the different characteristics of the neuropathies associated with multiple myeloma. So you have multiple myeloma without amyloid, multiple myeloma with amyloid. With amyloid caused the painful distal sensory neuropathy with autonomic failure. Without amyloid, distal sensory more common than motor neuropathy, and rarely sensory ganglionopathy or motor polyradicular neuropathy. Down here is the treatment emergent neuropathy of bortezomib, thalidomide, and vincristine. And you can see that the first two has a painful distal sensory neuropathy, and vincristine causes a distal sensory motor neuropathy with autonomic involvement. So we're going to talk a little bit about bortezomib and thalidomide. Bortezomib, the typical bortezomib-induced neuropathy is often a painful, sensory predominant, line-dependent neuropathy, where all sensory modalities are affected. The nerve conduction studies often demonstrate low amplitude sensory nerve action potential. The neuropathy often improves or resolves within weeks after stopping the medication. A small subgroup of patients develop a severe motor predominant polyradicular neuropathy with electrophysiologic features of conduction block and elevated CSF protein soon after commencing bortezomib. Thalidomide-induced neuropathy may occur in 50 to 81% of patients with underlying myeloma and depends on dose and treatment duration. The neuropathy is usually sensory predominant, and symptoms include painful paresthesia or numbness. The neuropathy is line-dependent and can progress to involve the hands. The symptoms can present after treatment has stopped and may progress for several months after discontinuing thalidomide. The nerve conduction studies demonstrate a reduced sensory nerve action potential amplitudes and may show reduced compound muscle action potential amplitudes as well. The severity and reversibility of the neuropathy depends on the length of the treatment and the cumulative dose, and nerve damage may be irreversible. In the case of multiple myeloma-associated peripheral neuropathy, the mainstay of treatment is to treat the plasma cell disorder, and this is done with autologous stem cell transplantation and varied chemotherapeutic regimens. In the case of treatment-emergent peripheral neuropathy, dose reduction or removal of the offending agent is recommended when possible. And this is the last section of the talk. We're going to review some about Point syndrome. Point syndrome is defined by the presence of polyneuropathy, organomegaly, endocrinopathy, M protein, and skin changes. It is also called Crawford-Case or Takatsuki syndrome. The serum M protein is usually IgG or IgA subtype and almost always lambda light chain restricted. Almost all patients with POEMs have sclerotic bone lesions, and whether there is a true distinction between osteosclerotic myeloma and POEMs is under debate. In all cases, the peripheral neuropathy is the dominant symptom, and that is very important because they are major criteria and minor criteria for Point syndrome, and there is a table that I'll show you in a little bit. The peripheral neuropathy is required, one of the required criteria. The neuropathy is homogeneous and recognizable as a chronic distal and large fiber sensory motor neuropathy with symmetric proximal spread. The weakness is usually severe, such that some patients become wheelchair and bedbound. is often mistaken for CIDP, as both presents with subacute motor predominant polyradicular neuropathies with areflexia, has less marked prolongation of the motor distal latencies, has more marked motor amplitude loss in the lower extremities, and is less likely to have conduction block. Pain can be a distinguishing feature from CIDP, as it is present in 76% of patients with POEMS and can be a prominent symptom. So the investigations for POEMS syndrome includes to search for a monoclonal protein. In POEMS syndrome, the protein is almost always lambda. If the patient presents with a CIDP-type presentation and a lambda light chain is found, then the neurologist should view this finding as a red flag and pursue further evaluation for POEMS syndrome. So anyone that presents with a CIDP-looking picture, we have to test them for a monoclonal gammopathy. And from this busy table, what I wanted to show is that mandatory criteria for POEMS syndrome include a polyneuropathy, typically demyelinating, monoclonal plasma cell proliferative disorder, almost always lambda. And there is many other criteria here. And then I'm going to discuss a little bit about this or show some pictures about this, because when the patients come to see us, we may see in their skin changes that go with POEMS, and that will be a clue for us. So this is on POEMS syndrome, and it's showing a coronal and sagittal CT of the thoracolumbar spine, showing multiple sclerotic bone lesions in the iliac bones and the thoracolumbar spine. So the treatment for POEMS syndrome depends on the number of bone lesions as well as plasma cell involvement of the bone marrow, and is aimed at treating the underlying malignancy. Currently, patients that have 1 to 3 bone lesions are referred for curative doses of radiation to the affected sites. Patients with more than 2 or 3 lesions or who have evidence of clonal plasma cell on bone marrow biopsy should be offered systemic therapy. There are several therapies from chemotherapy to autologous peripheral blood stem cell transplantation. So this is the glomeruloid hemangioma that can be seen in the skin of patients with POEMS syndrome. And this is hypertrichosis and acrocyanosis in the hands of a female patient. Too much hair and darker skin. Hyperpigmentation and white nails. Okay. So the evaluation for POEMS syndrome includes a skeletal survey, bone marrow biopsy, the plasma vascular endothelial growth factor level of more than 200 picograms or greater, albuminocytologic dissociation of CSF, which is the elevated protein in the absence of an elevated blood cell count. The nerve conduction study in POEMS syndrome also support a primary demyelinating process with secondary axonal injury. The nerve conduction studies are similar to CIDP but have greater axonal loss, a reduction of motor amplitude, especially in the lower limbs, and increased fibrillation potentials and a more uniform slowing. The underlying mechanism of the neuropathy is unknown. Patients with POEMS syndrome do not respond or respond poorly to conventional therapy used for CIDP, plasma exchange, IVIG, and oral steroids. So cases of suspected CIDP that do not respond to expected treatments should therefore be evaluated for monoclonal plasma cell proliferative disorder. We may be treating the wrong diagnosis. A peripheral neuropathy can be, this is a conclusion, a peripheral neuropathy can be the presenting symptom of a patient with a hematological malignancy, so we have to keep that in mind. The time from presentation to intervention can be shortened if we screen the patients appropriately for monoclonal gammopathies and do an early referral to hematology. The evaluation and treatment of peripheral neuropathy on a patient with a monoclonal gammopathy requires close collaboration of the neurology, the pathology, and the hematology services. And these are some of the review articles that I found helpful and that most likely I'll be referring to if I were, to see a patient with an MGUS. The first one is recent from muscle and nerve. It's called paraproteinemic neuropathies. The second one is the one in continuum. The third one is an older one from 2011, where I found this very helpful too, Neuropathy and Paraproteins, Review of a Complex Association. And that one is an older continuum from 2012. And then also I use a chapter that Dr. Batul has written in this book, Neuromuscular Disorders in Clinical Practice. And as you see, her, Myrna Rosenfeld, and Stacy Rudnicki collaborated on that chapter. So this is a complex topic and a complex association. I still think it's worth it to take some time and look into these things because it could be very good, very helpful for our patients.
That's a very good talk. I learned a lot from that. So basically, what you talked about are neurological complications of plasma cell disorders. What do we know? I don't know this, but what do we know about risk factors for plasma cell disorders? We know that we know about a lot of risk factors for different kinds of malignancies. What do we know? Or do we know anything about risk factors for plasma cell disorders?
Yes. This was not what I was trying to concentrate when I was doing the topic, but I came across articles that show that there are risk factors. You see, there is a familial form of this. And these patients, that have family members with MGUS and have neuropathy, they most likely will have an MGUS too, just for having family members that have MGUS. But also, I found recent diagrams explaining particular, genetic places and mutations that can predispose you for MGUS and malignancy, for Waldenström macroglobulinemia and for multiple myeloma, including things like diet and your weight and exposures and things like that. So,
What kind of exposures? Like radiation? Or?
Radiation is one of Nagasaki group has something like twice as often.
Yeah, there is literature on that. But I don't remember all of the detail, but there is it's well described.
I seem to think also that there has been shown to have a relationship to Agent Orange in the VA system. If you develop one of these conditions, you can become service-connected disabled based on that.
So what are your favorite medicines for neuropathic pain?
Neuropathic pain. My favorite medicine is Lyrica.
Is what?
Lyrica. I like Lyrica a lot. I also like nortriptyline, tricyclic antidepressants.
So just a quick question. Thanks for the lecture first. So my question is that patients with multiple myeloma, even if they are asymptomatic, before they commencing the treatment for the chemotherapy, did they go into recommending nerve conduction study EMG before commencing for that, even if they are asymptomatic?
I believe so. So we know how they look before and how much we can blame on the multiple myeloma or
just
the underlying process, and then after treatment they can get worse. So that way we know we can distinguish one from the other. That would be helpful.
Well, I have a sort of a medical economics question for you. And we see a lot of patients with neuropathy. A lot of them we will never find out what caused it. But let's say if a patient comes in diabetic and is fairly typical diabetic neuropathy or a long-time alcoholic, do we need to get electrophoresis on these patients? If we do, what is the best test? Is like the immunofixation? Is it the best one? And also, do we start ordering these antibodies, which can be very, very expensive, or do that later on in the process? How aggressive should it be in testing it?
As I prepared the talk, I thought about that. Because I don't know, but I try to standardize what I do for my patients so I don't leave anything out. I try to do the same thing. Although you still, as a physician, has to take a case, things case by case. I don't think that having one diagnosis, will make you immune to having another diagnosis. The American Academy of Neurology, they have put together recommendations in terms of what are the high-yield laboratories that we should do in all patients that are evaluated for peripheral neuropathy. And that includes to check some sort of test for diabetes, hemoglobin A1C, or fasting glucose tolerance test. They include B12, and they included SPEC. I don't know why they did not include, they also include methylmalonic acid level to make interpretation of your B12 level. I don't know why they did not include the immunofixation. If we all know, every time you read an article, they say immunofixation has to be done because some M spikes are going to be small, and you're going to pick it up with the SPEC. So immunofixation is one that I would include. And then, particularly the population that I'm serving right now. And the other thing is the free light chain, because primary amyloidosis can present with, we said mainly the small fiber neuropathy that is painful with autonomic features, but I have a table in the same review that I mentioned that has multiple other presentations for amyloidosis, for primary amyloidosis. So if you really want to make sure it's not that, you have to do a free light chain evaluation. So I think it's time saving.
Is this a urine test or a blood test?
Serum. I think that it will save money in the long run if you see the patient at once and do the right screening in one visit, because having the patient come and go several times and then miss a diagnosis and then, evaluate later on when have complications can be a disaster for the patient. And we're missing the diagnosis, we're missing the point. So again, different clinicians think differently, and everybody should review this data and arrive to their own conclusion about how they want to approach these things. And again, taking consideration case by case, how do we do these things? So, a lot to learn.
Symposium on stroke research here at 11, not here, but over in the radiology department, if they all are interested in that.
Is this yours, Steve?
No.
Oh, there's a bunch of them.
Would you hand me one of those, Steve? Thank you.
Oh yeah, I got the days. So I hear that.
Morning, Dr. Lee. How are you?
All I know is,
Well, they told me that
who we get one of those cheapest.
Hey, Dr. Ross. Good morning. How are you?
They stopped me after
Very good.
Bien. Gracias.
Muy bien.
Muy bien.
Yeah, I get those
Muy bien. De muy.
romantic.
Oh yeah. Very
They have a
similar.
lot of influence. They get fucking.
Like you, me.
When you were doing
Oh, Dr. Becker from Argentina.
That counts as Spanish.
Yeah, absolutely.
Yeah, right.
Thank you, that went well. Yeah, it's very interesting. I need to read more.
It's actually pretty good.
yeah, he's fine.
Are they expensive? It's
Not the one that got booted.
No.
Yeah. I'm sure they are.
You ask him something and he follows up on it.
He's actually very helpful.
Morning, Dr. Sarah.
Morning. You have
You want to go see that patient?
Yeah, I want to see Miss Watson or whatever.
She's doing better.
Yeah, and then you have patients with
Hey, Rachel, do you have Eric's number? Oh, wait. Never mind, I lied.
Scott.
Hey, Kaczynski.
And you learn a lot doing them.
Yeah.
Everybody did.
Everybody.
I went through and well, what I did was I went through and started doing shit. This is just that one word. No. Okay, all right, I can't even get pissed about that. I Googled it and it was. And the thing about it is too, is we're supposed to be trying to get away from that type of stuff, right? I gotta sign in. Did you guys already sign in? Hey? Huh? Did you already sign in? Yeah. But it's going back to that patient facility. Man, thanks for that caliper, dude. Oh, no problem, buddy. Yeah, tell him that. You signed in? Yeah. Probably still right there. Yeah, I don't think that comes out very far at all.
Oh, I'm looking the wrong side. I deleted it from here. Thank you.
Did she love it?